Assalamu alaikum everyone. I'm Dr. Vinesh Sayyed and I'm infectious disease consultant at Ghatak National Hospital. And I'm very pleased to introduce Dr. Naseem Salahuddin, who has been my mentor and my teacher at the Indus Hospital. She's going to give you some guidelines and some tips regarding this ongoing COVID-19 pandemic. So can we begin our session now?
Okay. Yes. Hello, Vinesh. Assalamu alaikum. Nice to see you.
Assalamu alaikum, madam.
Kaisi ho? Theek thaak? Good.
I'm
okay.
good, alhamdulillah.
Thank you for the introduction. And I'll just get on right away. I think I'll get off that because you don't really want to see me all the time. You get distracted. All right. Assalamu alaikum and good morning, everybody. Thank you all for being here on a Sunday morning to talk about this very, very important subject that has been the topic of the year right from the beginning of the year, and we need to discuss it in a lot of detail. For the next 10 or 15 minutes, I will introduce the highlights of the COVID-19 outbreak and how it is happening, not in a lot of detail, but enough for everybody to sort of get into the understanding of how, when, and what. Whatever I'm going to present is not the final word. Obviously, there are a lot of changes. There are going to be a lot of changes during the rest of the outbreak, maybe for a whole year or two. We don't know right now. But you know, what we're talking about today may not hold water tomorrow. So, but I'll give you the update on what is happening right now. Oops, it's not changing. Now what has happened? What is happening? We can pause. Or
what? Can you go?
It's not moving.
So if you just click the yeah.
No, that's
no. If you go back to whatever you clicked, and then you know the down button, you've got 4 arrows. So you just not with the cursor.
One second.
Okay. Yeah.
No, I'm stuck. Okay. Yeah, that's fine.
Ahmad, can you play?
Yeah. No, sir. She has to.
Okay. Just need to use the
okay,
you've got the arrow at the bottom or the next button.
Okay. So just to begin, really up to date,
yeah,
as of today, there were 1.7 million confirmed cases around the world in 211 countries and more than 103,000 deaths to date up till yesterday, but probably since last night, there might be many more. And as you can see on the world map, most countries are now affected. Just to tell you the difference between seasonal viral influenza and the COVID-19, because most people think it's the same as influenza, but they both belong to different families. One is the orthomyxovirus and the other the coronavirus. They are both enveloped viruses. One is negative, one is positive. And the R0 is different in both, and I'll tell you about that in just a little while. Case fatality is different. There is no antiviral for COVID. There is antiviral available for influenza, and so on. So just want to make a point that these are two different viruses. Everyone knows that in December 2019, there was a series of pneumonia cases in China, and that is what has gone viral. And at that time, the whole genome sequencing was done from lower respiratory samples in Chinese affected people. And it was found then that this was a brand new virus, and they named it SARS-CoV-2. And the disease that caused it, and the syndrome is known as COVID-19 because of coronavirus 2019. So first announced on the 31st of December while people were celebrating the new year. Corona, as you can see in the cartoon on the right, it's got these spikes, which is why it is called corona, because it looks like a crown that is placed on the head. It circulates all year round. There may be reinfection, we don't know, and there may be a lot of asymptomatic infections. But this is a group of viruses that can cause minor symptoms like just a minor cold, 10 to 30%. Occasionally, it can cause viral pneumonia. And the SARS-CoV virus in 2002 and the MERS-CoV virus in 2012, 10 years apart, caused more serious diseases. They were less transmissible, but higher mortality. Just quickly to show you the difference between the three on this slide. The SARS-CoV virus of 2002 caused 10% deaths, and the MERS caused 37% deaths. SARS-CoV-2, the present epidemic, pandemic, we don't know right now, but it's a moving target. The pathophysiology is the same, and they both affect the upper and the lower respiratory tract systems. This is the reproductive rate called R0. And if you look over here, MERS, what it means is that one person can infect so many people. This is the reproductive rate, meaning one person can transmit the infection to as many people. MERS, only one person, Ebola, 2 persons, influenza, the common influenza, 2.5%. COVID is also about 2.5%, meaning one person can infect 2 to 3 people at a time. And if you notice here, measles can infect 15 people at a time. So this has the highest R0, 15, R15, okay? Yes, transmission of COVID, we all know, is a person-to-person spread among close contacts, meaning less than 3 feet, via respiratory droplets. And it is always person-to-person. It is no more, there's no intermediary host. So humans are the reservoir of this infection. And the main source of infection, it is highly transmissible. Notice this has 2.2 to 3 R0. So that's how fast it will spread. Most people are contagious when they are symptomatic, but we really don't know how much an asymptomatic carrier is able to infect others. So this is also something we don't know. But when the infected saliva falls on a surface and somebody touches the surface and puts it to his nose or eyes on the face, it can get easily transmitted. So touching a surface that has a virus on it is also transmissible. Rarely it can be a fecal oral route, but that is mainly in children. If they have acute gastroenteritis, they can present, but this is rare. But basically we have to understand that this is a person-to-person through the respiratory route. Majority of infections luckily are mild. 80%, 81% people recover, especially those who are young. About 12% people have it more severe, and about 5% people get it more critically. And out of those who are critical in the ICU, admitted to the ICU, half of them are put on respirators. Other half maybe get better after a while if they're well looked after with proper oxygenation, or the disease has not affected bilateral lungs, then they get out of it. But those who are on the ventilator suffer more complications. And it is these people who have cardiovascular disease, poorly controlled diabetes, chronic respiratory tract disease, and those whose lungs have been affected by damaged by old tuberculosis or chronic smoking or something, they are more prone to getting more critical disease, and they're the ones who tend to die. The incubation period is a range of 2 to 14 days, but a mean of 5.2 days. It depends upon the viral load that the person opposite has inhaled. More virus you inhale, the more severe is going to be the disease. The more the person is immune compromised, the more severe will be the disease. So most infections start with rhinorrhea, sneezing, sore throat, but the target of the virus is the lower airways, meaning they go down the trachea into the bronchi and then into the lungs. And this is where the damage is done. As you can see on your left, the alveoli are affected. There's a lot of things one has to understand in the pathogenesis, which I don't have the time to explain all that. But look at this picture on the right. This is a scanning electron microscopy of a virus on lung tissue. Maybe this is the alveoli, but it's not one or two virions, it's millions of viruses that latch onto the alveolus, and this is where the pathogenesis starts. I mean, this is really a scary looking picture, but this is essentially how it looks on the respiratory epithelium and the alveoli. Chest X-ray can be different kinds. They can have multinodular appearance in this one, or they can have consolidation, unilateral, bilateral. The more severe the disease, the more, I mean, the more it affects one lung or both lungs. The more severe will be the outcome. And here you can see in the CT scan. CT scans are pretty specific. These nodules here. In fact, the Chinese would bypass many times the instead just go directly to the CT scan, and they would find that these people are infected with corona. Patchy ground glass. All right. Older the person, the higher is the case fatality ratio. Case is CFR. Case fatality ratio means the denominator, the total number of people that are affected, and the incidence of death. So that is the CFR, and it is highest in older people. Well, let's start from below. Younger people are less affected, especially children. We're not quite sure why, but anyway, older people tend to have more underlying disease, so maybe that's the reason. And as you get older, the mortality is higher. And then, as I explained earlier, more underlying diseases, the more is the mortality. And somehow more men tend to have disease more often than females. So we as females have a little bit of edge protection over the male. These are some of the very important prognostic markers. Of course, you do the CBC and LFTs and so on, but notice that they have lymphopenia. Lymphocytes are very low, and the low, sometimes as low as the overall lymphocyte count. The lower it gets, the worse is the prognosis. High D-dimer, CRP, ferritin, procalcitonin, these are also very good markers, and the higher they are, the worse is the prognosis. High CO2 and shunting. And one thing we're learning here is that high trop levels indicates that the muscle myocardium is damaged, and a lot of people have myocarditis. In fact, at the Indus hospital right now, we have, I think at this point in time, 2 people with myocarditis, very low ejection fraction, and I don't know if they'll make it. This is a dangerous sign, and it's always in the older people. So the lab diagnosis, we're all familiar with the real-time reverse transcriptase PCR, which detects the RNA of COVID as extracted by RNA extraction. But because sometimes it may be negative, okay? But as I explained earlier, that even influenza and other respiratory viruses, paramyxoviruses, parapneumoviruses, they also resemble, they also may present with pneumonia. So if you have a negative COVID-19, it is possible that there may be other respiratory viruses. And if you can do it, go ahead and do a PCR testing to rule out other viruses so that you're not suspecting this is a COVID-19. What you do is get the nasopharyngeal or oropharyngeal swabs from the upper respiratory tract, or if you're doing a bronchial lavage, then you can get bronchial washings, but then you have to be thoroughly prepared and wear appropriate PPE while collecting the specimens. You can't take a risk with this. On the right-hand corner, you see that there's a swab put up in the nose. You tilt the patient's head backwards and stick the swab. It's not the ordinary cotton swab. It's a little different, different fibers, so that and then you rub it thoroughly, and put it in the collecting tube and send it off to the lab as soon as you possibly can. If you can't do that earlier, then put it in the refrigerator at low temperature, 4 degrees, and then transport it over to your lab. You can also do the oropharyngeal swab, stick it in the oropharynx and rub it nicely so that you get as much secretion as possible onto the swab, and then you'll get a better result of, if you don't do it properly, if you don't get enough virus particles onto the swab, you can get a false negative result, and then you'll think that this is negative. But this has to be done like all culture tests. You have to do a proper collection. There's much talk now about rapid diagnostic tests, and I've been reading a lot about it, but what I say today may not hold tomorrow. Basically, what happens in the antibody test is that the IgM, person gets the infection. On the 3rd to the 5th day, the IgM antibodies are released. And if they're in sufficient quantity, then you can detect it by the specific antibody test. It's a very simple test, really. Much like you would do, say, for dengue, you can detect the IgM very quickly in the 3 to 5 days, or you can do the antigen test in dengue. But we don't know much about it. And then the IgG, which is a more permanent and long-lasting antibody, starts to go up on day, say, 5, 6, 7, and then it peaks around day 14, 16, and hopefully it'll plateau or go up, and then plateau, and then may last for years and years. But then we don't know about this virus. It is so new that it's something that we'll be learning about. What is being told about us is that the result comes within 15 minutes, which is a point of care test, POCT, point of care test, and you'll get the result within 15 minutes. I mean, that would be brilliant, wouldn't it, if you could just draw the blood sample, and if somebody had IgM, and you say, okay, this person has the disease, active disease, because IgM is still very early. On the other hand, you draw the sample and you find that IgG is detected, then you will think, okay, this person has now recovered and developed immunity. So you're very happy that this person is now safe and not, again, vulnerable to COVID. And it's a very small, it's a very nice test. It's just a small slide. They have different techniques like lateral flow, that immune chromatography, but you don't have to know that in detail. The lab has to know it, and I understand it a little. And a lot of companies are marketing it, and especially in USA, one company, I'm told, has been approved by FDA, but not the others, and they're still being tested, so don't trust it too much. Just like the dengue virus antigen detected, this test is also available, but it is being tried out in China and maybe in USA, and it is not yet approved. So just hold tight and hope that this comes through in the next few months, and then we'll have something, either we'll do it or we won't do it. We don't want to waste our money in laboratories getting this test when we don't really know the validity of it. There's no real treatment. So far we've been giving supportive care. If it's a mild infection with just a runny nose, nazla, khansi, zukam, then we will just treat it supportively with paracetamol and bed rest and, like a simple viral infection. Put the patient in quarantine, and that's the best way to not spread the infection. If it's a moderate infection or a severe infection, then people are very nervous about it. And a lot of people in China and now in USA are using chloroquine, which you and I have used forever against malaria. And now we suddenly find out that it is also has some antiviral properties. We know that dihydrochloroquine, which we've used for a long time in treatment of connective tissue disorders, has a modulating effect, meaning it has a immunosuppressive agent. So that is why it works in say, rheumatoid arthritis, other conditions. And so the same effect will also be in reducing the severity of COVID, but we really don't know. And then people are using also azithromycin. I'm not sure why they're using it to protect against bacterial infection. But for you and I in Pakistan, this is going to be something very hazardous because we need to conserve our azithromycin because we're seeing a lot of XDR typhoid, and we as physicians, ID physicians, are very nervous about it. So don't get into the azithromycin very easily. And then remdesivir has been tried in Ebola, it works. And maybe there's something in common with the Ebola virus and the coronavirus. So remdesivir is being tried and anti-influenza drugs are used. Lopinavir, ritonavir, which we have used a lot in treatment of HIV/AIDS very effectively. These are protease inhibitors. And maybe that protease present in the HIV virus is also present in the coronavirus. So this is why it may be effective, but we don't know. Then you've been hearing a lot about cytokines being released, which is your IL-1, IL-6, tumor necrosis factors. So anti-cytokines can sort of, if you're thinking like it's a sense in a, like a fire breaking out, the anti-cytokines will help dissolve the fire. And we're talking about the convalescent plasma collected, about BCG. This is all up in the air. And maybe in the next few months, we will have better understanding, but don't depend on any of these things yet. Vaccine is a distant dream right now. It'll take many months, maybe a year, year and a half. It is in preparation. But by the time it comes to be useful globally in you and I, it'll be a long time. Itna jaldi nahi hota ye. Okay. Now, we come to your protection. The general infection preventive measures. Just look at this slide. This man is giving a nice big sneeze, and the particles, the nasal particles, which are pretty large, relatively large, because they're heavier, they fall to the ground within 3 feet from here to here, okay? But some of the particles which come out very fast, like an aerosol, just think of a can of some spray and you spray it hard. So some of these particles are very fine, and instead of falling down very quickly, they spread all the way out for a couple of feet, and they may spread out into the air, maybe not air, especially in a closed room, which is air conditioned, your windows are closed. So this can land on any surfaces, on the wall, on your furniture. And this is where the new understanding is that it can spread further than 3 feet, which makes sense to advise people that they should sneeze into the elbow so that the spray doesn't spread around, so that you should wear a mask or use a tissue and discard it properly. So some of these precautions are absolutely essential. So in general, you and your colleagues and your family, everybody must understand cough etiquette, meaning sneeze or cough into your elbow. Wear a surgical mask in case you have a respiratory tract infection or when caring for one with RTI. There's no need to wear a mask in the open air. I mean, people are walking along in parks, on the road, or by the beach where the breeze is flowing nicely and people are wearing masks. It doesn't make any sense. But yes, it is very useful if you're in a closed place, if you're going shopping in a grocery store and a lot of people, you might as well wear it. Otherwise, you're just wasting it. And it's not just that you wear it for one time. You've got to change your mask frequently. Just wearing it on your face looks more decorative, and it makes other people panic, and then there's a lot of hoarding, and then the masks become scarce, and people who really need them, like we all healthcare workers, we find that there's no available good masks, and then people make homemade masks. We don't know how secure they are. So please just advise your people not to wear it all the time. Maintain a safe distance. This is very, very, very important. Keep your distance for the reason that I explained in the previous slide. Don't use your mask today, tomorrow, day after, day in and day out. throw them away because when you're coughing, sneezing, the the sputum collects on the inside and it loses its efficacy. So discard that and use a new one. But then you don't have so many new ones. So as I said, wear it only when and where you need to wear it. And when you do wear it, make sure you wear it in the right way. Cover your nose, your mouth, and don't keep fiddling with it. Kabhi upar kar rahe, niche kar rahe. Just be very, wear it in the proper way, and then wash your hands because you've touched your mask, you've touched surfaces. So you need to do that. Now, coming to you all as surgeons, this was the basic things that all of us should be doing. Now, those of you who are working in any healthcare facility, and applies to you all as neurosurgeons, most important thing over and over again is stress hand hygiene before and after dealing with a suspect COVID patient. Droplet and contact precautions with simple isolation, airborne precautions, appropriate PPE, and PPE, or of course your personal protective equipment consists of gloves, gowns, eye shield, and mask. Depends upon what you're doing, who you're in contact with, but these are the PPEs in general. When you wear a PPE, make sure you know how to wear it, donning and doffing. Practice it. There should be drills for how to wear it, and we've been doing that at the Indus much before we even opened up the corona ward. Everybody is made how to, depending upon what task you're going to perform, whether you are a laboratory personnel or a nurse or a doctor or a surgeon or whatever. So PPEs, number one is the simple, so-called simple surgical mask. It is this, if it is WHO, properly made according to their approval. It consists of 3 layers, outside, inside, and one that touches the wearer's face. And it actually, it's got enough, it's got small pores so that the tiny viruses and bacteria don't go inside. And it also prevents the wearer's secretions inside the mask to stick onto the inside and doesn't go outside. So it works in both ways. And here this person is also wearing a eye shield so that somebody else's secretion don't get onto her face. This is a simple, so-called simple surgical mask. Then you have the respirators. And respirators come in different protective levels. This over here is a common one that we wear in our hospital. It's called the N95 mask. And the 95, 95 means it protects 95%. Then there are those, I think this one, which protects N99, and it protects 99% of the virus getting in. This one over here is also a respirator, but it has a filter so that the moisture doesn't accumulate. This is for people who are working in higher areas where you do, for longer time, and the moisture collects on your glasses and fogs it up. So this is a better way. We at the Indus, when we do TB patients, we wear the N95, but again, you have to wear it properly. And I can't teach you over here all the wearing, the donning and doffing, but it has to be done in a special way and worn correctly. And then you have this hazmat suit, looks very dramatic with a hood and mask and gloves and the whole body suit. I don't know how effective this is, but those people who are wearing it in China, they have very high quality stuff. I hope this also works, but this is only for people who are working, say, in the lab and there'd be spillage, or people like you all who'd be working as surgeons in the theater. So these are some of the things. Then there is the powered air purifying respirators, PAPR. And this is something which is, to me, very dramatic. Just look at the equipment over here. It has a mask, a hood, and then it has a filter. This whole thing, it is battery powered, very, very sophisticated. And It is used for people who want to keep chemicals out of their system, bacteria, viruses, who work in very high, densely packed areas. I don't know if you've ever used these. I don't believe anybody in Pakistan would have this. I don't know really, but you could tell me. But this is something quite a heavy and fancy thing that you would, and it reduces the risk of exposure more than all the respirators. So general plan, you know, when you have your clinics, when you have working in a hospital, make sure that your hospital supports your plan of action. You must have supportive hospital administrators. Your consultation room should be well ventilated, not necessarily air conditioned, but you should have fans and the window open. It depends on what your situation is. You must have all your supplies of PPE, that is hand sanitizers, tissue, mask, proper disposal of tissue and mask, and good hand sanitizer with more than 70% alcohol. There are a lot of fake sanitizers around the market, and they may not be effective. Your staff must know how to triage patients when they come in to see you. Right at the desk, your staff must understand enough what questions to ask, how to screen people, and if they have any suspicion of this being an active disease, why then the proper precaution must be taken. Maintain your distance wherever possible. It's not always possible because you have to examine your patient. Take in only one person at a time with the patient. And of course, you have to be wearing your PPE also. Now, for all types of surgery, I know you surgeons know better than I do that you should be doing and not be doing elective surgery. Postpone them as much as you can. We don't know when this pandemic is going to end, but the decision has to be yours because you're the one who's going to take the risk. But if you have an emergency surgery and if it is life-threatening, then you as good-hearted neurosurgeons will put your lives at stake and say, "Nay, I have to do this. This has to be done, so take the precautions." Before you take in the emergency surgery patient, just think in your mind, yes, this patient may be infected. I don't know, this may be infected. So that person should be verbally screened for COVID. You know, all the questions must be asked, and we know what those are. I can't go into detail over here, meaning their symptoms, where they came from, have they been in contact with somebody with COVID infection? And if the answer is yes or no, then you make your decision. But if you have anybody with suspicion, please call your ID consultant. You have now ID consultants in many hospitals around Karachi and in Pakistan, so get them into the decision making. But if you absolutely have to do your surgery and if it's urgent, then better to do the RNA PCR, and most places will give you the answer now within the same day in 6 to 8 hours. Some places may give you in 24 hours, but it depends upon the ability of the lab. They can give it very quickly. It's not really a big deal anymore. And if it is positive and you still want to do the surgery, then you must be properly dressed with all the PPE as much as possible. Your OT must have negative pressure. Okay, I know your OTs are always air conditioned, so we can't say open the window and open up all the fans, but you know, you must have negative pressure. Your lives are at stake. Please avoid any procedure. I'm nobody to tell you what to do, but you must not attempt procedures which need drilling and burring, because that will just spread the virus far higher, and you know, like an aerosol from the patient's nose, mouth, and it will just spread higher. So use your judgment. Patients who do not require suction are a little less contagious, but anyway, there must still be droplet and contact precautions. Preferably keep the patient in, you know, when they're moved out, keep them in a single room. All healthcare workers, please, over and over again, I say, wear the proper mask at all times during patient care. Strict hand hygiene, avoid touching the eyes and mask. Over and over again, I have to tell you the same thing, but this is for you to follow and keep yourself safe and your family safe and healthy. And before you You don't want to go outside and talk to the family wearing all your PPEs. So remove properly in the room or in the ward, immediately perform hand hygiene, and then go and talk to the patient. Patients who require intubation, extubation, or suctioning, while they pose a very high risk to you all. Airborne isolation with contact precautions is a must, and that is why they should be in a negative pressure isolation room. Or when they're not in they've been discharged from the operating room, placed in the room. If you don't have negative pressure isolation room, at least make sure that the windows are open and the fan is blowing away from the patient to the window, so that the bugs, if they're there, they're cleaned out by proper natural ventilation. Don't have people coming in and out of the room. Non-essential person must not go. Only one dedicated caretaker who's wearing the proper PPE. This is something that, and once the patient can be moved out of isolation after 2 repeated nasopharyngeal swabs are negative 24 hours apart. Okay, so that is important. Then you know that the patient is non-contagious and can be de-isolated. Dealing with a suspected case, it is an algorithm, doesn't show up very well. It's very busy slide, but get your ID consultant. I think they're pretty self-evident that whether if there's no risk, then that's okay. If they're suspicious or whether they're proven, then these are some of the things that you do. But at all times, proper PPE and hand wash. Inpatient management, infection prevention considerations: avoid moving and transporting patients in and out unless if it is medically necessary. I mean, if you don't need to do a chest x-ray or an ultrasound every day, try not to do that. Use a designated portable x-ray equipment when you're moving in and out, or when you absolutely must have these tests done. And use predetermined transport facilities to minimize exposure for the staff and visitors. And I mean, again, makes sense. And HCWs, again, I emphasize, must have the proper PPE done in the proper way. Keep the patient only in the designated area. Your healthcare workers must use a single-use or disposable or dedicated equipment like stethoscope, blood pressure cuff. Keep it there in the same room. Don't use from room to room. If equipment needs to be shared, then clean and disinfect by using 70% ethyl alcohol. Environmental cleaning is important. Laundry, food service, utensils, medical waste, all these have to be taken into consideration through your infection control and prevention nurses or the department, and discharge the patient as soon as possible. Of course, when you're certain the patient should be discharged, with clear instructions on how to prevent getting it or giving it to others at home. There's something that the British people made this in UK, and it is nice looking plastic box, which is open only towards the head, where the anesthesiologist is intubating or suctioning, but it's covered so that if the patient gives a cough or a spasm or something, then the virus is not dissipated into the air. And it offers a protective screen against droplets, which are generated during airway procedures, which always contain high levels of the virus. So this is a nice thing. I don't know if you all have it, but it's not been patented or approved as yet, but this is something that they're using and might be nice. It is also nice so that you can, the nurses, healthcare workers can provide mouth care of the endotracheal tubes. It will protect your nurses, healthcare workers, and prevent the disease among medical personnel. Even in give you emergency protection. You just put that box on top of the person and hope for the best. At least it's better than having somebody open and coughing or giving a jerk or when you're suctioning or something like A lot of people ask, what if the patient has a cardiac arrest? Should you really do a CPR on these people? You know, every time you push on the chest, you're moving these secretions up and they can spray. So CPR is done on patients who are pretty close. So think twice about doing a CPR, especially without having, you know, a good, understanding of what is the patient's prognosis is going to be. But if you feel that it has to be done, you wear an FFP mask. It's a filtering mask, and there's FFP 1, 2, and 3. And 3 masks are the most filtering masks of all the FFPs, and it gives 99% filtration and only 2% leakage. You know, no mask is perfect other than the PPRA, but FFP masks are very good. I don't know if we have them with us over here, but this is just on the side for people who would be doing really a very difficult task like a CPR. Make sure after you've left the theater that your staff properly cleans, disinfects the contaminated surfaces. The virus is more sensitive to UV light and inactivated at very high temperature. Of course, you can't use high temperature of 50 degrees for 30 minutes in most, of course, you can't do it on equipment. But if you lipid solvents, just even soap and water, scrub thoroughly on all the surfaces is very effective because that kills the virus. And if you use 70% ethanol or chlorine containing disinfectants, chloroform, I find, but not chlorhexidine. Chlorhexidine we use to scrub patients, but this is not a very effective way of disinfecting contaminated surfaces. For your home use and also in hospital, a very good surface agent for cleaning contaminated surfaces is 1 to 1,000 dilute bleach. Scrub, you know, it's cheap, it's effective, and you can clean your floors, your walls, your doorknobs, tables, handrails, everything very nicely with that. We don't know for sure how long a virus can stay alive on most surfaces, but it can be from 3 to 12 hours, even 72 hours on stainless steel. Okay, that's about nearly 3 days on stainless steel, but if on paper and cardboard, it's less. And so if you can clean with a diluted bleach, that would also help. You know, tell people not to wash their newspapers and envelopes with bleach, but you know, it doesn't stay long on those. Other areas for you as physicians to pay attention to is the waste management, environmental cleaning, and safe burial practices if it comes to that. The national NIH, the government of Pakistan has made a National Action Plan for Preparedness and Response to COVID. This is February 2020. It's very exhaustive, I think about like 25 or 30 pages, but it changes as new information comes in. Finally, if you want to assess yourself on whether you have COVID or whether you have any tendency, then go to this link, copy it down if you like, in English or in Urdu, and it has a set of questions. And if you don't qualify for testing, it will tell you. If your numbers are higher, it will advise you to go for testing and to, you know, whatever else you have to do. Yeah, I find this very effective. So spread it out to your colleagues and other people around. So my colleagues, please stay safe. Everyone, you, your colleagues, your healthcare workers, assistants, your families, good luck. Thank you for listening if you're still there.
Dr. Naseem, thank you. Wonderful talk. Really enjoyed that. Vinesh, you want to take away from there? You want to ask a question or two?
Thank you, Dr. Salman, and thank you, Dr. Naseem. That was a very useful and nice talk. I would like to invite the participants of this meeting to, if they have any questions, they can go ahead and ask Dr. Naseem. She's still there. So any questions from the audience? You're welcome.
need to be typed?
They can also type, and I can read it out, Dr. Naseem, for them in the chat.
Dr. You are an expert also in infectious diseases and control. Answer.
Sure.
हाँ जी शुरू करें. Dr. Lal, आप पूछिएगा if you want.
Really, it was a very nice presentation, and we get a lot of information, madam.
Thank you.
If anyone can ask, want to ask questions, they can ask. Whether should I ask some questions?
Dr. Naseem, Dr. Yusuf, who's my chief resident, he's there, and he's got few slides, so maybe we can have some revision regarding what you've just said. Sure. About neurosurgery, and especially pertaining to some procedures. So I think, Yusuf, if you're there, can you share your slides with us, and just we can go through these 6-8 slides with Yusuf.
Assalamu alaikum.
Wa alaikum salam.
Okay, so that was a very, thank you, Dr. Naseem. That was a very comprehensive talk on protection against COVID-19. So I'll be just covering a couple of slides regarding the procedures that we do and how we should be going about it. So in general, can everyone see the slides?
Can you put it on?
Okay. So in general, when in our neurosurgical practice, our objective should be to, number one, reduce number of attendings. Now, reason being that we all know that we are not doing elective cases, so this would dramatically reduce the number of residents that are required for the management of the hospital services. And since we are only dealing with emergency cases, so we can have significantly reduced number of doctors taking care of the hospital setting. And the second important element is that it is important that senior decision making should be done at the first point of contact. This is important, reason being that a senior can usually identify sick patients. And if the patient is relatively stable, and the senior can often identify such patients, and this can avoid successive examinations. So this will dramatically reduce the number of repeated examinations that would be required. Therefore, this is one of the important elements. As we have already talked about, that elective cases should be postponed until the pandemic is over. And now that we are extensively relying on online-based sessions, so we can have good oriented web-based clinics. So clinics can be conducted through online consultations. When it comes to trauma management, well, we cannot go away from the basic management protocols of ATLS. So we'll be dealing with trauma patients as per protocol, and we'll be admitting these patients, but we can slightly reduce our threshold for, or we can, I mean to say, we can slightly elevate our threshold for admitting patients, particularly patients with concussion. If you think that the parents are educated, you can educate them and discharge patients with concussion. If the CT scan is not indicated, do not do an unnecessary CT scan, because CT scan is one of the modalities that is used extensively to evaluate patients with pneumonia who have COVID-19. So I'm not sure how well our CT scan machines are cleaned between patient to patient, but because a lot of patient turnover occurs within the CT scan machine as well, therefore avoid exposing your patients to unnecessary CT scan. If the CT scan is required, then obviously get it done. Only admit patients who have reversible intracranial pathology such as extradural, subdural, hydrocephalus, depressed fractures. Obviously, these are the cases that need admission, sorting, and you need to do this as you have been doing. Plan early discharge and home care, because this is one of the important elements. In terms of tumor management, we need to identify our patients who are high risk and low risk. High risk patients are those that we need to address in the coming days or so. These patients can usually not be postponed. And for these circumstances, if at all possible, if you are doing a simple biopsy, use a simple daycare surgery. Do not admit patients overnight, if at all possible. And the lesions that you would like to operate or intervene are predominantly posterior fossa tumors because they are causing either symptomatic hydrocephalus, meningiomas, which are causing significant mass effect, deteriorating neurology, or hemiparesis, supratentorial brain metastasis, which are subjective to complete treatment. Reason being complete treatment, that it is a single metastasis, large, causing life-threatening symptomatology, and other type of tumors such as tectal gliomas or those tumors which are causing hydrocephalus. Again, in these circumstances, if at all possible, you need to do the minimum possible. If it is hydrocephalus that is causing problem, then just do a diversion procedure. That is an ETV, a VP shunt, and the definitive procedure can generally wait a couple of weeks. Similarly, low-grade tumors, low-grade gliomas are those in which you can adequately wait a conservative period of time. Therefore, you can follow these patients over a month or 2 months. Therefore, immediate intervention is not needed. Skull-based tumors like meningiomas, vestibular schwannomas, most of them can be managed and operated at a later date, provided that you have addressed the hydrocephalus. Again, it is one important thing that I would like to remind is that whenever we are delaying or the surgical intervention of any patient who has a tumor or has a spinal pathology, it is important that you document all these things, that depending upon the current clinical situation, so that we're not subjective to any liability later on. Because as we have seen that our guidelines have changed significantly depending upon the current circumstances. Therefore, we should document that. Second, in terms of spine, yes, again, elective discs or simple herniated discs should not be operated upon in these days. But if it is a symptomatic spinal tumor, spinal fracture with deteriorating neurology, spinal infections, epidural abscess, MMC, all these cases are emergent and they need to be addressed. As I've just given a single slide about what trauma patients, tumor patients, and spine patients need to be intervened upon, preoperative screening should be done when we are doing operation on all these cases. At least one COVID-19 test should be done pre-op before surgery. Even if the patient is asymptomatic, the guidelines that have come in from the neurosurgical societies and all those suggest that get at least one COVID-19 test prior to surgery. All elective cases should be postponed, and during procedures, as Dr. Naseem has highlighted about the new box that have come in, intubation is a very important procedure because this is one of the parts of the surgery where significant aerosolization can occur. Hence, all the personnel in the theater should be kept to minimum. And if you are operating on a COVID-19 positive patient that have come out to be positive, and he has a deteriorating neurology, a posterior fossa tumor, then in these circumstances, it is mandatory to use respirator. But at the same time, not all hospitals have respirators. So the guidelines are to, if the respirators are not available, N95s are good alternatives. Even if you don't have adequate supply of N95 masks, then an alternative is to use a surgical mask and tape it around the margin so that it tends to form a seal. So in these current circumstances, we cannot completely highlight what is right, what is wrong, because of the available resources in most of the institutions. But it is important that whatever you have, you use it wisely and postpone those cases which are COVID-19 if at all possible. Now, the most important element is that the transoral cases that we do. I'm sure that transoral odontectomy is not routinely done, so it would not be a big concern. But the nasopharyngeal approaches that we do to operate on the pituitary gland, this is done extensively. And because we are traversing a sinus or oral nasal cavity, this procedure is highly infectious. Hence, it is recommended that you ideally do not do these cases. Just don't do it. The only emergency in these circumstances is when the patient develops apoplexy or when the patient is showing aggressive visual deterioration. Even only in those circumstances you can consider surgery. But generally, if the tumor or if a lesion is causing visual deterioration, it must be huge. And if it is huge, you can obviously look for other alternatives such as transcranial approaches. So do not do a transnodal approach because it is associated with high risk of infection. Therefore, avoid that. Consider alternatives. Again, I would like to say that in many centers, neurosurgical practice, tracheostomy is routinely done. So delay all tracheostomies. Ask your ENT surgeons who are better at dealing with it to do these procedures for you if at all necessary with adequate equipment, but don't do elective tracheostomies. So this is just a brief overview of what procedures we should be doing and not. We have also recently published the guidelines on the PSN, which are there. And I'm sure that it has a much more extensive orientation of what we should be doing and what we should not be. So I hope that is sufficient. Over to you, Dr. Salman.
Totally agree. I think a very good brief summary of what Dr. Naseem has highlighted earlier as well. So if Beenish is there, he can get these questions and take them away and ask these questions. Beenish, are you around? Or have you lost her? Okay, I'll get these questions out if that is the case.
And I would like Dr. Naseem, can you hear me now? Okay,
Yeah.
I was muted by the host. Okay, so I'll repeat myself. So there has been a couple of questions, but unfortunately, I'm unable to see the chat that was previously there. So, okay, so, but fortunately, I have noted down the questions. I would not be able to name the participants who have asked them, but the main questions that they have been asking are about the use of PPEs. Okay, so here is Dr. Zubair Mustafa Khan. He has asked the question, for how long elective transnasal surgeries need to be postponed as pandemic is likely to continue for a year or so? So who would like to answer this question, Dr. Salman Sharif or Dr. Naseem Salahuddin?
I'll take it. The guidelines at the moment, we are saying postpone everything for 1 month and then we 4 to 6 weeks to start with, and depend. I think it's going to take some time. For example, transnodal surgeries we do for pituitaries. So if you are doing transnodal surgeries for pituitary, you could do a transcranial approach if it's really essential. If you think patient is losing vision and if you think there is really no other way, then you can do a craniotomy. One of my friend, I was telling Dr. Naseem earlier, is head of IFNE, which is our endoscopy world organization. And he was doing surgeries until last week, not realizing that it's unsafe. So I think it's important for us to know that it's unsafe to do endoscopic, any kind of a sinus surgery or an endoscopic skull-based surgery or transoral surgery. So the other option would be to look at other options. So we can do a craniotomy that we used to do before. So all that is, we can take it in another approach instead of doing the same transnodal approach. If a patient wants to wait, maybe you're talking about 2 to 3 months is the minimum time that I think would be safe. But to predict it's unpredictable. Nobody knows.
Okay. Thank you, Dr. Salman. The next question is for Dr. Naseem, and this is Dr. Saad Javed. He has thanked Dr. Naseem for the talk, and he has asked the question. He's asked the question that are there any neurological manifestations by COVID-19? There have been some reports of cerebral pathology, seizures, and one case of Guillain-Barré syndrome. So
I couldn't hear because of the background noise.
Okay, so I'll repeat the question, madam. So this is Dr. Saad Javed, and he's asking about any neurological manifestations that have been seen with COVID-19 patients, specifically GBM or any other or cerebral pathologies.
I think I was just reading lately that there were cases of GBS, Guillain-Barré syndrome.
Yes.
So that is the only neurological complication that I've heard of. Otherwise, basically, it's a respiratory tract infection. So whatever pathology is known that comes in the respiratory tract, in the lungs, pneumonia, and then the cytokine outburst, which sort of affects then the kidneys, the heart, the liver. So that's really a very far advanced complications, myocardium. I don't think I've read anything in the literature. It's too early, you know. By the end of the year, when we have more cases, people will start writing their reports and cases. So that will come slowly, but not as of now. Just GBS that I've heard of.
I think, Dr. Naseem, there are some cases of encephalitis, severe encephalitis, brainstem encephalitis. There are cases of stroke because of encephalitis. So those have come out from China that we've had. We haven't had any case from Europe up till now, but all these cases are from China. And up till now, what we have seen, that's a very rare sequelae at the moment. Obviously, majority of the time it's the chest.
Yes, it is. Yes, they have been reported very rarely. So the next question is, Dr. Adnan Khalik has asked the reason of high mortality due to COVID-19 among neurosurgeons. He has stated that up to 5 neurosurgeons have died. So would somebody like to shed some light on this? Why the higher rate of neurosurgeons dying?
I think same, the problem that we have had is that the first neurosurgeon who died was in China, who was doing that endoscopic surgery. And the whole team got infected. So anybody who was above the age of 55 did not survive in that. So that was for whatever reason. And since then, a lot of ENT surgeons, 41 ENT surgeons have passed away because of this throughout the world. So it is because they were operating on sinuses, they're using drills, and they didn't know, obviously, at that time. So I think all that is important. And even last week, I was talking to somebody, Samir Al-Baba, who's our friend in Florida, and they were doing a sinus surgery in a kid with COVID -1 test. And now they're waiting to see what's the result of the second test and waiting patiently. So I think, people who want to take risk can take the risk, but that means you're putting your whole staff at risk, and you don't want that.
This is the whole purpose of this webinar, so as to raise the awareness and place cautions before you. For God's sake, save yourselves. You're very valuable people, we can't do without any kind of surgery. You're there for us, and please just be very, very careful. Yeah.
So a couple of quick questions, probably from Dr. Naseem. So these were the questions I have noted down while we were having that presentation on the specifically on the neurosurgery.
Dinesh, your voice is breaking. Your connection, your net connection is not that good, maybe.
Okay, there was a question from Hassan Masood, and he said, can we use N95 masks for a week or so if we have limited resources? If yes, what's the protocol?
Okay, yes, you can use N95 for a long time, but if you wear it for the appropriate amount of time, don't wear it all day long in and out of markets and on the street and around, when you don't need it. So after you've used it, take it out properly and put it in a paper bag and keep it aside. In our hospital at Indus, I know this is now in great demand because of people who are working inside the wards. And they've been assigned just one mask for a whole week or 2 weeks, I don't know. But they get it, they write their name, they use it for the appropriate amount of time, put it away in a paper bag, not in plastic because that doesn't breathe, or, put it safely, and you can use it. But if it's shows signs of wear, the elastic is loose and it doesn't fit you anymore, then please don't use it. It's as good as wearing a mask inappropriately, improperly is as bad as not wearing one at all, because you still have leakage from around here. So wear it properly. Yeah.
Okay, another thing that I wanted to clarify is, our routine WHO authorized masks that we have in our, the surgical masks that we have in our theaters and in the hospital. I was reading somewhere their efficacy is equal to N95 as well if used properly, as long as there are 3-layered masks. Is that correct?
The surgical mask. No, N95 is a little more step above because the spray that comes from another person doesn't go in that rapidly. These are very fine pores. We use it all the time in when you're treating TB patients, you know, drug sensitive or drug resistant TB, because those bacteria are a little larger. But even with the COVID virus, which is much smaller in micro nanometers, microns. See, the advantage of a regular surgical mask is that your sputum doesn't go out, and what is outside just sticks to the surface of it. In the N95, the bugs wouldn't go in at all because they are so small. So there is a bit of an advantage of the N95, but because these are more not that easy to obtain, so we save them for people who are doing procedures where there's going to be an aerosol or larger number of viruses. So it's more advantageous for that reason.
Okay, so then there is a question from Abrar Sheikh. Can we touch surgical mask after cleaning our hands, sensitizing them, or having food? Can we touch them, remove them, and then wear them back on?
A regular surgical mask, it's better to just sanitize your hands, take it off properly, put it aside. If you want to reuse it, if it's clean enough and not really dirtied, and then maybe you can use it after a little while because you don't have so many, but always use clean hands for it. You know, now that we're running out of surgical masks, there are people who are making homemade or factory made masks. And there's a lot of debate about whether that is as effective as the WHO approved surgical masks, which are imported from China or wherever, I don't know. And those should be made of cotton with multiple layers. And you can wear them just like that. And you can also wash them with hot water, cotton masks. So if you don't have any other mask, even that is better than not using a mask at all. But for you people as surgeons, I would not have you take a chance. I know what you told me has happened to your colleagues. Just do the best protection you have. In answer to your question, always keep your hands sanitized and then take off the mask. And if you have to have your meal clean, sab kuch theek thaak karke, and then put it back. That's reasonable, I suppose.
Okay, then there is Nadeem who's asking, what is the role of prophylaxis hydrochloroquine?
Oh my God, I was hoping nobody would ask that really. Prophylaxis, you know, the Chinese come up with these new things all the time, that if you take hydroxychloroquine once a week for, you know, people who have not been infected, take it once a week for, I think they said 7 weeks, and see if you get COVID or not. It doesn't work out that way. You know, whenever you prescribe a prophylaxis or a treatment, you got to have double blind, you've got to have randomized clinical trials, and nobody's done that. So people have been trying this, that, and the other. We would absolutely do not recommend using anything prophylaxis. Otherwise, you know what will happen? You'll start taking HCQ, and you'll forget about hand wash and masks and distancing, and then gradually you lose interest in doing these proper methods. Chloroquine is not going to prevent. We don't know anything about it. Even as treatment, it is all up in the air because people are using for treatment in desperate situations 3, 4, and 5 combinations of hydroxychloroquine and azithromycin and antivirals and anti-HIV drugs. And then you don't know which one worked and which one didn't, or maybe the patient was going to get better anyway. So nothing definite as of this time. Wait till the end of the year or better experience.
Okay, we have another question regarding, there are a lot of gentlemen in neurosurgery with beard. And they're saying when using N95, can we use a normal mask underneath and then put N95 on top? And would that help even with having a cover to save the filter of the N95? Do you think it's worthwhile doing that?
See, beard, it depends on how long or how short the beard is. But whenever you put the mask around here, there's always going to be some gap if there's something protruding from your chin. It's always better to have it on a clean shaven face, okay? But culture and habit and so on doesn't allow that all the time. We people of different habits and practices. So best thing is, of course, keep it as short as possible and cover it. I know you surgeons, many of you have longer beards and even do surgery normally. You know, before the time of COVID, So what did you do there? After all, you were not really properly covering up your face. There's always a leakage. And here, since this is a very highly transmissible virus, you have to be as sure of not letting that bug go in as much as possible. And this is why we're talking about you all doing surgery, very high risk with a lot of aerosolization. So you can't afford to have a beard, long beard, improperly covered, and then hope for the best. Please pay attention to yourselves. I'm not giving you any fashion ideas here, but this is not for fashion. Do it later on when COVID is over. Go back to your old habits if you want to, but for now, please pay attention to yourself.
So there are lots of our friends who have asthma, and so the risk, is it very high, and what are the chances of them catching disease versus somebody who doesn't have, and do they need to take special precautions?
Yeah, they have to take special precautions if they've had recurrent episodes of asthma. But if they're absolutely stable for a long, long time, then they're as much or little risk as the rest of the world is. Of course, if you have other comorbs along with it and your age is more than 60, 65, then you're at higher risk. But keep your asthma under good control. If it is not under good control and you have attacks frequently, then I would be worried for you. Yeah, then you should not be performing.
Okay.
Sorry, go on.
Yes, Dr. Salma, you can go on, please.
No, you can ask. Can you see the questions now? You're back?
Yes, I can. There was some connection issue previously. So Dr. Zubair Mustafa Khan has asked you what are the current recommendations for routine PPD, OPD, sorry. What their concern is basically, do they need to continue the elective OPDs or just restrict themselves to emergency cases as in need? Because we all know that there's a lot of risk involved with doing OPDs because we don't know what kind of patients are coming in and what kind of people have also been asking what about, do we have to wear gowns along with the surgical masks and gloves? What kind of appropriate PPE is recommended as in the outpatient department? I think Dr. Naseem would like to answer
the
this.
people who are at doctors who are at highest risk for getting COVID are ENT, ophthalmologists, dentists, and maybe sometimes dermatologists, because they have to be at very close range with their patient. But as for you all, it depends on how closely you need to examine your patient. But first things first, as I said earlier, your staff outside your consulting room should have this questionnaire. Screen them out. And if their patient is honest enough to give you honest answers, okay, no, they have no risk, so but they should be wearing a mask, and you should always be wearing your mask, not necessarily the whole gown. If you're not doing a procedure, if you're just talking to them or examining them, if there is any sense of any risk, then you have to be more alert, send that patient out for a test, and avoid seeing such a patient who's clearly symptomatic or highly suspected of being symptomatic. So again, it's a matter of working it intelligently, and it's not you alone, but it's your staff out there who has to ask the right questions. If you remember the first case that was found in Karachi, that gentleman who had come from Taftan through Iran, and the Taftan, no, he didn't go to Taftan, he came directly from Iran to
Karachi.
And then he moved around in Karachi University, he went over the place, may have infected a lot. And then he came to Aga Khan University Hospital to the ENT clinic. And there the nurse, who was very smart, she said, do you have any symptoms? Why are you here? He said, I've just come from Iran. I've got a cough and fever. So she did not let that patient come in. She made him wear a mask, took him to the lab and had him tested, and he was positive. So that one person could have infected a whole lot of doctors, ENT people who were not aware of this infection at that time. So again, going back, be very careful whom you screen, and be prepared anytime that you may inhale bugs. But we come back again to the mask, proper wearing of mask, proper hand sanitization, your furniture, your table, your chair rest, so on. This is how
okay, just another question from Prakash Moda. He's our friend from India. Prakash is a dear spinal surgeon from Ahmedabad. So he's asking, does anesthesia flourish the disease?
Anesthesia, well, I think the anesthetist is at risk, clearly, because he's doing the intubation and monitoring. So everybody is at risk. Anesthesia per se, no, the patient, I assume, is lying unconscious, deeply sedated. So I don't imagine that would be at risk. You people are in the theater and would evaluate that as a risk, but it's the person doing it who's at risk, the anesthesiologist.
Lal, you have a question?
Yeah.
Yes, a question from Mohammed Mehboob. He's asking, do we need screening for COVID before performing tracheostomy who are admitted with severe head injuries or require long-term ventilation for neurosurgical diseases? I think this question is for Dr. Naseem.
Sorry, cleaning what?
Screening for COVID before performing tracheostomy. So the patients.
Yeah. I think it's best that you screen, and it's also, you don't know. So I think it's better to do the PCR test, provided you get the results back very soon. If it's a very urgent surgery, then it's better to do a PCR test, provided you get the results back within 4, 5, 6 hours.
And if that is not possible, then what do you suggest we do?
If
not getting the results,
surgery has to be done. You neurosurgeons would decide. It's a question of life and death. So you decide, and if you decide that you really want to do it, you have to do it without any report, any result, then do the maximum PPE that you possibly could. All the things that we've talked about.
Okay. Thank you, madam. I guess this question is for Dr. Salman Sharif. It's Dr. Ijaz. He's asking what is recommended for a burr hole in emergency, a craniotome or with brace?
I think, yeah, two things regarding tracheostomy. There is no doubt in my mind that we should defer tracheostomy as much as possible at this time. If you don't have proper gear, if you don't have 2 COVID negative, then do not do a tracheostomy. CT chest is essential to look at what the chest is like. And if it's COVID positive, think 5 times before doing it, because you're going to involve all your staff. They're going to get infected. You don't want that. So if at all possible, avoid doing a tracheostomy in present circumstances. If you really have to do it, you have to have the whole gear. If hospital can provide you, fine. If they can't, you should not take your life at risk. It's very simple. For drills, we have already discussed that when we use drills, there is aerosol coming out, although it hasn't shown that for making a burr hole on the head itself increases the chances of any kind of risk, because we haven't seen it in blood, we haven't seen it in CSF. So it doesn't seem like that, but in present circumstances, ideally we should not use any kind of drill, but use manual burr holes at the moment. So that may be the best way to do things for time being. If you have good protection, then yes, it's possible to use, we did a couple of craniotomies a few days ago, we used it, but we had proper gear and, we were ready for it. So you need to be ready for what you're doing. You don't want to be giving any risk to your colleagues. It's very important.
So at this point, I would like to ask a question from Dr. Naseem. Madam, in our setup with limited resources and limited number of tests available, what do we still recommend? I know neurosurgery people ask for 2 COVID negative tests before going for a procedure, but is it possible to do that in our resource limited settings? And what are your recommendations regarding that?
If the first test is negative and you're still uncertain that this may be a COVID patient, then yes, it's reasonable to do a second one. Again, you can get false negatives, as I said earlier, if the swab is not properly turned around and you don't have adequate specimen in that, then it'll give you a false negative. And you want to do it the second time to be absolutely sure, why then you can do it. Yes, we're resource limited. We are short of kits right now. Use your judgment in that. Dr. Salman just said a minute earlier that you may, if you can't get a test, do a CT scan. But then Dr. Yusuf earlier said it's, you don't want to waste that test. It's an expensive one, a lot of radiation. You have to take the patient to the radiology unit. So it's a matter of how you balance out. But whatever you do, whether it's a suspected case, a confirmed case, the only salvaging way is to do your good PPE. In the end, it comes down to that. Every possible way.
Yeah, I think guidelines at the moment worldwide is that neurosurgeons should not take a chance. They are, I think, too expensive compared to a CT or a test. I would say that, because they are made over years and it's a lot of effort, and, you don't want to be losing them in any way. And the staff they have is all future budding neurosurgeons. So I think it's very important. Their anesthetist there. So I think you need to look at the whole scenario. Yes, life-threatening scenarios are there, but I think we need to balance that. And if at all possible, avoid any surgery in the present circumstances. But you really have to do that. Hospital should provide you 2 negative tests. Hospital should provide you with all the gear. Otherwise, you don't want to be a martyr. And tomorrow in the news, you come, we have all these news all over the world where all these, 101 doctors have died all over the world. We can't have that. 41 and ENT people. These are all people who have put in their whole life learning. They are full of all this knowledge. They have just gone away like that. There's a neurosurgeon from New York, a very good friend who passed away, who was master in separating conjoined twins. And they televised his life, 2 cases on CNN for 8 hours straight, just to show what he was doing. And this guy is no more with us because he was operating. And I think we can't do that anymore.
Yep.
Any more comments?
Another question from Sana Zuhaib. Is there a need to go for disinfection of our wards more than that was routinely done? I think that this question is for Dr. Naseem, I guess.
Sorry, I didn't hear it because of some noise here.
Okay. Yes, Madam. Dr. Sana is asking, is there a need to go for disinfection of our wards more than that was routinely done?
Okay, wards, meaning all the, tables, bed railings. Yes, those should be cleaned more than before, because this is a new era of COVID. And this, as I keep saying over and again, it is more transmissible than any other disease because it comes out in large numbers. In the bacteria, the viral load is very large. Somebody sneezes or touches this. It's best always to clean it thoroughly, and we should be doing that normally anyway. But here, if one didn't do it, then I think this is a good time to revise one's habits and do it more than ever. Yes, absolutely.
Okay, so there is this one last question. Asif Awan is asking, is doing endoscopic approach better than open one? I'm sorry, excuse me. Better than open one in terms of control of infection spread?
I think a surgeon could answer that.
Yes, I think this question is for Dr. Salman.
Yeah, I think, we have discussed this again and again. At the moment, do not go through any place where there's mucosa. Do not work in an area where there is high virulent bugs sitting there. And we use debriders, we use drills, we use ultrasonic aspirators. Everything causes aerosol to come out. And so we really can't do that at the moment. If you really, I have like 4 or 5 urgent cases that I needed to do. And all of them I explained to the patients that these are the risks and, it's better that we wait. And all of them are waiting. If I require to go in, if it's urgency, I would do a craniotomy. I would not go through an area where, we can cause serious issues to our patients, even if it's an asymptomatic patient. Why would I like to take that risk at this time? There is no way I would take that risk.
Okay, next question is also for you, Dr. Salman. Mr. Adibul Hassan is asking, should we use PPE for every case in emergency surgery or only for suspected cases? Because it takes more than 24 hours to get the COVID result. So if we go for testing for suspected case pre-operative.
Dr. Naseem has clearly said before, every case that's coming in is a suspected case. So yes, clinically you can rule out some cases, but there is maybe asymptomatic and a weeks down the road, they could be very symptomatic. So I think the important thing is, you have to have COVID negative. If you can't get a COVID negative result early, you can judge yourself. If you have proper gear, do it. If you don't have proper gear, please send the patient somewhere where they have proper gear. Otherwise, just 2 or 3 surgeries during this time will not get you anything. You and your staff are too precious for us. So please try to avoid any kind of emergency surgery unless you have no other option. But you have to think that you have to protect yourself. So if you don't have a N95, for example, use double mask. I did not have N95, so I was using double mask all the time. So, and we use shield as well, and we use proper gear. So I think you need to be careful, and you need to know what patients you'd operate, what patients you won't. And that too, what we do is anytime we have an emergency case, is discussed with head of the department and head of anesthesia. And if they both agree, then we do that case. If they if one of them disagree, we do not, because the safety of anesthetist is as important as the surgeon. And we have to be careful for our staff, those scrub nurses. Everybody is important to us. And if they stay there, then we'll be able to help other people afterwards. If they don't, then, if, for example, the whole staff goes in isolation for 14 days, if nothing happens, just asymptomatic, you've got 14 days of those people not working for you. So you need to think about it.
Thank you, Dr. Salman. So I don't think there are any more questions left. So
I would get Lal Rahman to say a few words before we go away. Lal, you've been very quiet all along. We're sorry. Your voice is I think, what you're using is giving us trouble. Yeah, go on.
Thank you, Dr. Salman. Really, it was a very informative session, and we learned a lot from this session. I think as a neurosurgeon, we receive a lot of emergency patients. So we should consider all of these patients as COVID positive patients until proved otherwise. But one thing is that in our hospital, even this is not possible to get the screen test for our own doctors. So how can we do this for all our patients? So I think we should do something for this thing. And because every day we are doing emergency surgeries, at least 4, 5, or 6 emergency surgeries, and our doctors are very prone to infection. So what can be done in that condition?
You need proper gear. And if you don't have proper gear, tell a government that you won't operate. Do not take a risk. If you can get COVID negative, fine. Do not operate on people taking risk on young guys who are. Okay, sorry, we are just running out of time. It's actually 30 seconds to go. So before we wrap up, I thank Professor Lal Rahman there. Beenish, you've been excellent. All the people who joined, asked questions. I can see Shamsuddin there. Professor Naseem, I think it was such an informative talk. We really enjoyed it. And everything that we know just solidifies, and you just summarized everything so nicely. We are grateful to you. Yusuf, my chief resident, excellent talk, and thank you for all the answers and patience that everybody has taken, and we have learned a lot. Sorry, we are just disconnecting now. So thank you very much. Thank you all.
Thank you.
And tomorrow we have Professor Atul Gol from Mumbai. He's going to be talking about skull-based surgery. Hello. So that's it. So that's his radiological diagnosis of CV junction problems. Atul is a world famous CV junction surgeon, and he's going to be joining us. And